সোমনাথ বাবু
হ্যাঁ শুরু করুন
Good morning, my senior professors and my colleagues. Today my topic is management of carbapenem resistant organisms, what lies beyond and what is the new era of antibiotics that is coming up. So before I start, I will just go 15 years back when I was completing my internship. When I started my medicine posting, my senior house physician Dadas told me I can only write ceftriaxone and cefotaxime. So this was my drug and also his drug, and I cannot go beyond that. And if our senior consultant sir, if he chooses, he will maybe prescribe a piperacillin like that. So that was maybe a 15 years back. And when I was completing my internship, our medicine professor, Dr. Datta, told me there was a new antibiotic which is coming up, which is hitting the market. That is the meropenem, and it will be a magic drug. It will solve all our problems, and the future lies with meropenem. So down the line, 15 years after that, today we stand with a huge amount of carbapenem resistance. At least it is touching from, it is ranging from 40 to 70%, and it is maybe 40% among Klebsiella, E. coli, and 70% among Klebsiella. So the magic drug is gone. So we have lost all the magic, and now we are thinking about what drugs we have after meropenem, after carbapenem, what we have now. So today's main discussion will be what are the new drugs and how we can safeguard those drugs, so that maybe another 15 years down the line we lose all those drugs and our future generation will have no drugs. So I am very worried about that, because I have 2 kids. So let's discuss about how we can approach. So antibiotic resistance, antimicrobial resistance, this is a major health problem all over the world, and we face it more in the third world countries, where the infection rates are high, where the population is very high. There are multiple factors that contribute. We have a high burden of infectious diseases. So in the tropical, we live in a tropical country, we will have a high burden of infectious diseases. Unregulated sale of antibiotics, this is a major problem in our country. Patient expectations, this is mostly seen in the peripheries, where the patient go to a doctor and expect that he or she will get some antibiotics, some good drug, maybe 3 or 4 drugs. Otherwise, they are not satisfied. So there is always a patient expectation, and maybe the doctors also prescribe along with that. Limited public health response, and this is the most problematic thing that we face. That is over-the-counter prescriptions. So today I have maybe a common cold, maybe a slight rise of fever. So I don't go to a doctor. I just go to my nearby pharmacy shop and ask for a drug. They just give me 1 azithromycin, 2 azithromycin, maybe 1 coamoxiclav. We pop the pill. Viral fever gone in 2 days. We stop that antibiotic altogether. So like this, we are just increasing the antibiotic resistance. So there is no regulation, nothing. We can easily get any antibiotic from the counters. This is also a problem, non-prudent use of antimicrobial agents among some of us. So these are all the factors which contribute to antimicrobial resistance. So now, what is carbapenem resistant organisms? So what are these? So we can broadly divide into 3 classes. First is the carbapenem resistant Enterobacteriales, that we previously knew as Enterobacter C. The nomenclature has changed now. So first group is the carbapenem resistant Enterobacteriales. Second, we have the CRPA, that is the carbapenem resistant Pseudomonas aeruginosa. And third, and the most notorious that we have very limited drugs for, that is the CRAB, that is the carbapenem resistant Acinetobacter baumannii. So these are the 3 major groups of carbapenem resistant organisms. So first we look into this carbapenem resistant Enterobacteriales. So what we have in this CRE, we have E. coli, we have Klebsiella. These are the bread and butters of our everyday work. And we also have the Protei group, that is the Proteus monocolonna providentia, and also Serraceae and others. So how can we define carbapenem resistance among these? So CDC defines as the resistance to carbapenem, so non-susceptible, The MIC value is more than 2 for doripenem, meropenem, artapenem, as imipenem, and more than 4 for dori, mero, and imi, and more than 2 for artapenem. Or we have a documented production of carbapenemase. There are multiple potential mechanisms of this carbapenem resistance. We can also, again, I will not go into details, but we can broadly divide into carbapenemase production and non-carbapenemase production. So this carbapenemase production is a major part of this carbapenem resistance, and non-carbapenemase productions like maybe protein channel loss, mutation of PEPs and others, efflux mechanisms. There are multiple mechanisms. This comprise the non-carbapenemase production. So why are we worried about this carbapenemase production? So if we know if one isolate is carbapenemase is producing carbapenemase, and if we know exactly which carbapenemase it is producing, we can decide what antibiotic to give and what to not. So we can select our antibiotics according to this carbapenemase production. So this I will discuss later on. So first, we will just quickly look into this classification of beta-lactamase. We don't need it in details, but we will just see this class A, B, and C, A, B, C, and D. This is the Ambler classification of beta-lactamase. Class A comprises of ESBL, that is the TEM, SHV, CTXM, and KPC. KPC is the carbapenemase. So I am not discussing about this ESBL production. I am only focusing on carbapenemase. So class A consists of KPC. Class B, it comprises of NDM, IMP, and WIM. NDM is the most important carbapenemase in our country. It is named after our capital, New Delhi, beta-lactamase. So class B is the NDM, IMP, and WIM. Class C, MC is very rare in our country, and class D is OXO48. So among these 4 groups, we can see that only the beta-lactamase is only the class B, and the others is the serine carbapenemase. So this will help us later. Now we will just we don't have any guideline of our country, so we will just rely on USA. So we will see what are the guidelines of IDSA. This is the Infectious Disease Society of America. What they are saying, and some modifications from our country also. There are many papers and journals. We can discuss it. So firstly, what are the guidelines of CRE? CRE is the carbapenem-resistant enterobacterias. So if it is a uncomplicated cystitis, we can give fluoroquinolones, nitrofurantoin, aminoglycosid according to the sensitivity pattern. We will follow the culture report provided from the microbiology lab. Second option is meropenem standard infusion. If artapenem is resistant, meropenem is sensitive, and carbapenemase production is negative. This is very tough to achieve in all the setups, because we don't do carbapenemase for all the patients. We don't do all the carbapenemase tests for all the isolates. So maybe we will follow this fluoroquinolones, chlorotimoxazole, nitrofurantoin, and aminoxidil as the preferred treatment. In the second line, I have highlighted ceftazidime avibactam, Cas-Avi. There are other drugs also: meropenem, vaborbactam, imipenem, relebactam, cefiderocol, etc. and etc. So these drugs, among these, only ceftazidime avibactam is now currently available in the Indian market. The other drugs have hit the European market, but it hasn't come here. So we only have this Cas-Avi, that is ceftazidime avibactam. So second line treatment for uncomplicated cystitis is drug of choice is ceftazidime avibactam. Colistin, we will leave it as the last resort. We will not use colistin. We will not use colistin because we have to keep aside colistin for the most notorious infection, that is the crab. Because in crab, we don't have any other option other than colistin, minocycline, and sulbactams. So we will try not to use colistin in every patient, in each and every patient. We will try to safeguard colistin because in my personal experience, in my last institution, I have seen colistin resistance go up to 12 to 14%. So that is very, very concerning. So we will try to avoid colistin as far as possible. Second is the pyelonephritis or CUTI. CUTI is a complicated UTI. It can have it is a UTI with a structural and functional abnormality of the tract and a male UTI. So a male patient having a UTI is always complicated because it will have something. It will have a posterior urethral valve. It will have a benign posterior hypertrophy. The patient can have a BO, the patient can have a vesicoureteral reflux, and so on and so forth. So male UTI is always a complicated UTI. In complicated UTI, the first drug of choice will be again Cazavi. The other drugs are not available right now, so I will not mention them again and again. We can use meropenem extended infusion if, again, the meropenem is susceptible, artapenem is resistant, and carbapenemase production is negative. This is a bit tough to achieve. Again, I am telling this. So I have highlighted it in orange. So we will try to focus on ceftazidime avibactam. Second line. Extended infusion, it is the extended infusion increased dose. Extended infusion is over 3 hours, as it is a time dependent kill. Meropenem acts as a time dependent kill, so we will infuse the drug over 3 hours, and it will be an increased dose, not the standard dose. MCI we can do that. MIC, sir, we will not rely on MIC, because meropenem is already raised, but like meropenem, it is a carbapenem resistant organism. So we are dealing with a carbapenem resistant organism. Here it is artapenem resistant and meropenem sensitive. So meropenem is already sensitive, sir. Yes, sir. Yes, sir. And the organism is a non-carbapenemase producer. In that case only we can use this. So I am leaving it. It is a bit difficult.
Duration of the
drug dose is also double. Yeah. So increased dose and increased duration. And off-label যেটা আপনি জিজ্ঞাসা করছেন সেটা হচ্ছে 4 থেকে 8 এর মধ্যে থাকলে তাই করে 8 এর উপরে মানে 4 থেকে 8 এর উপর হলে everyone you are telling the highest recommendation or everything. Yes, sir. They usually do. Sir, more than 4 is resistant. I am telling it is sensitive. MIC value of more than 4 but less than 8. They do it. Yes, sir. Yes. Yes. Off level. Yes. Secondly, we can use once daily aminoglycosides. This is a very good option. Because we have got very good results with amikacin, we have got very good results with gentamicin, and maybe we can use it once daily, so the nephrotoxicity will be much less. Next, the third option, again, this infection outside the tract, and that the isolate is meropenem sensitive, artapenem resistant, and carbapenemase production is negative. We can use meropenem extended infusion as a preferred treatment, and alternatively we can use Cazavi. Fourth infection is outside the urinary tract. Drug of choice again is ceftazidime avibactam, Cazavi. And alternatively, we can use cefiderocol. We can use tigecycline, but tigecycline is not a very good drug. It has only action in intraabdominal infections and SSTI, skin soft tissue infection. So we will not be able to administer tigecycline for each and every patient. We have to see what is the source of infection. Then we can think about giving tigecycline. So in this again, the preferred drug will be again Cazavi. Fifth option, now we are doing the carbapenemase test, and we have found that there is a KPC production. Sir, pardon? আচ্ছা স্যার না স্যার ভালো পরিমাণে আছে, অক্সাটা কম আছে, অক্সা কম আছে, কেপিসি আছে, এনডিএম বেশি, NDM is ranging around 55%. KPC non-existent, NDM and oxa is very common. NDM is our production. It is New Delhi Medical Diagnosis. It will be here. So now, because we are not testing, madam, we have to test to find out. We don't have that much data. We don't have much data. Sir, I am doing this for the last 2 years. What I have found is majority is NDM. It ranges around 55 to 60%, and then comes KPC, and then comes oxa. Sir, in oxa. Sir, this changes. This varies. This varies from time to time. Now, at this moment, sir, KPC is on the rise. So this is this. If KPC is a KPC producer, then we can use Cazavi. meropenem vapor-bactam and imipenem relevactam. And second line again we can use tigecycline, but tigecycline is limited. Cefiderocol is not in our market. And last but the most difficult to treat, that is a metallo-beta-lactamase. If it is a metallo-beta-lactamase producer or a co-producer, like we have actually, sir, what is the main thing is that we commonly get co-producers in India. We don't. Yes, the co-producers is much more prevalent. Like we get a KBC plus NDM or a OXA ASA. So this is the scenario, sir, right now. So if we yeah, absolutely, sir. Absolutely.
That should be a very important point in your lecture. What we can do now?
Yes, I am coming, sir. In the later part of the lecture, sir. So in this we can use Casary plus Aztreonam combination. So it has a synergistic action. So Aztreonam acts against the MBL part, that is the metallo-beta-lactamase part. It neutralizes the metallo-beta-lactamase, and Casary acts against the others. So this is a synergistic combination. The combination it is a very high good result. Like it is effective in 80 to 85% cases, and we can taste it also in the lab. Alternatively, we can use tigecycline again, but tigecycline is use is limited. So this was the CRE. Now we will focus on CRPA. That is the. Pardon, sir? Oh, hi, yes. Oxides is Casary. Sir, combination will come only if we have a metallo-beta-lactamase co-production or metallo-beta-lactamase single isolate. So if it is a single OXA 48, we can go for a Casary. We don't need a Aztreonam. But the main problem is, sir, now we are getting co-producers mostly. Yes, ma'am. Yes, ma'am. Because metallo-beta-lactamase are against only Aztreonam box. Others don't work. No, sir. Simultaneously. Simultaneous infusion for 2 hours. Both. Yes, sir. No, the recommendation is simultaneous use, sir. Simultaneous use, otherwise the synergy will not happen. No, sir. So it should be used simultaneously.
Why it is known as Trojan horse? Because sectors transporter involved করে আমার মনে হয় এটা অ্যাবিভ্যাক্টাম আর অ্যাস্ট্রিওনামটা কাজ করে সেপ্টাজিনটা কাজ করে না বিকজ
yes sir
অ্যাবিভ্যাক্টাম
yes sir
we don't have Avibactam separately. What we have, if you want to use Avibactam, you have to
yes sir
use combination.
Yes sir, that is why the new drug is coming. Aztreonam Avibactam is coming.
This is known as frozen horse.
That is why, sir, that is why the new combination is coming. That is in the pipeline. It has already crossed the phase 3 trial. That Aztreonam Avibactam. Maybe it will hit the next year. So that is also coming. So now we will focus on CRPA. That is a carbapenemase resistant Pseudomonas aeruginosa. More or less, it is same. We will again prefer the preferred treatment will be again Casary and Ceftriaxone tazobactam. If it is sensitive, we can use. There is a very good drug for Pseudomonas. And alternatively, we can use colistin, but we will try to keep it as the last resource. Pyelonephritis, again, preferred treatment is Casary. Second line, maybe we can use aminoglycoside. If it's sensitive, and outside the urinary tract, again we will have the preferred treatment as Casary. So now coming to the third group, that is the most notorious. That is the CRAB, carbapenem resistant Acinetobacter baumannii. So for this, we have very limited option, very limited scope. The ceftriaxone Avibactam goes away, so it is not active against Acinetobacter baumannii. So what we have here, we can use sulbactams. Sulbactams may be combined with ampicillin, maybe combined with cefoperazone. We can use sulbactams. Second, and the maybe most commonly used is colistin or polymyxin B, depending on the site of infection. Thirdly, we can use minocycline. That is a very good drug for CRAB. Very good drug. If it is sensitive or maybe intermediate, If it is intermediate, we can combine it with colistin. And then we can use high dose of tetracycline, but again, tetracycline role is very limited because it is only intraabdominal and skin and soft tissue. And acidoreductor mostly infects the chest. So tetracycline, maybe we can keep it aside. And then the fifth option is this high dose extended infusion meropenem. We can combine it can be used as a combination therapy with colistin. Ideally, colistin now here I have written monotherapy and combination, but the recent recommendations which are coming that colistin should not be used as a monotherapy, as it is not a very potent drug. We should, whenever we are thinking about using colistin, we must combine with something else, maybe a meropenem, maybe a minocycline, whatever. But if there is a culture report, we can use. I have also used sulbactam with colistin. We have got good results. So we have to combine, and we should not use it as a nebulizer. In many places we use colistin as a nebulizer, but there is no proven benefit as if we use colistin as a nebulizer, and the drug distribution is not uniform. Maybe we can have a life-threatening bronchoconstriction. So we should ideally leave colistin. We should not use colistin as a nebulizer.
If you have Acinetobacter which is resistant to cephalosporin sulfate, so we know this sulfactam was very good. Can we use cephalosporin?
We can use as a combination, but ideally people try. We can use when sulbactams any of are. So we yes, it is also available. We can use the sulbactam. So but ideally in this situation, what the scenario you are telling, we have to follow the hospital antibiogram. So what we had for the last 3 months, for the last 6 months, I will come to that. I will come to it later. If the sulbactam is if the sensitivity to sulbactam is good, maybe we can use it. Otherwise, we should combine meropenem with colistin in that scenario. So now the first part is over, and I will just briefly go into the molecular testing, how we can do this, and how it helps in selecting these antibiotics. So shall I continue, sir? Okay. So what molecular testing we can do? What are the modalities we have in hand, and how it can help in selecting the proper antibiotic therapy, so that we don't beat around the bush. So of course the thing is that it is much faster. We can get a result in 1 hour, maybe 1 to 4 hours, depending on a lab, and it is of course beneficial for the patient outcome. So what are these RDTs? RDTs is the rapid diagnostic tests. What are these? So we have PCRs, we have multitops, we have a microarray, we have a PNF fish. So mainly we will focus on PCR because PCRs are available in the most setups. So we will not go into others. Yes, sir. So I will focus on PCR. Yes, sir. So PCRs we can. There are 2 methods. We can do an open PCR and we can do a cartridge-based PCR. So ideally, the cartridge-based PCR results are much more much better than those open PCRs, because the analytical error and the operator error is negated. So what are these closed PCRs? We have a gene expert machine and we have a biofire machine. So I will come one by one how those can help. Before I tell this is a sample report. I will just quickly go into it. So what is CARBA-R? So in this CARBA-R test that we go do in gene expert, we can map all these CARBAPENEMASEs all together. So we can map KPC, we can map OXA48, we can map NDM, VIM, and IMP, and all these we can do within 48 minutes. What are the samples we can take? 48 minutes, sir. What are the samples we can take? We can take a rectal or perirectal swab from the patient. We can do it from the isolated colony from a clinical sample, what we have got. So what is the benefit of a CARBA-R? So I will just give an example to clarify this. I have a critical patient with sepsis who has come. Maybe I have started meropenem. I have the CRP, maybe it is ranging around 280. The procalc is also high. So I have sent a culture report, maybe 2 or 3 cultures to the lab. So I have continued this meropenem for 48 hours. Maybe the CRP has come down to maybe from 280 to 260. I don't know if the patient is improving or not. And after 48 hours, microbiology report is negative. So here comes the dilemma. If we continue the meropenem, or we escalate the antibiotic, or we de-escalate the antibiotic, whatever. So I don't know if my patient is responding, because if I start meropenem, the patient will respond somewhat. So what do we do? So we continue meropenem for another 10 days. Now the CRP maybe comes down from 260 to 100, but the patient is not better. And after 10 days or 12 days, the patient starts deteriorating again. And then we think about, okay, then we have to escalate. So this escalation, we can do it after 48 hours if we do a rectal or a perirectal swab. If we straight away see that the patient is colonized with CARBAPENEMASE producers, if we see that the rectal swab is showing KBC production or an NDM production, we will not continue that meropenem. Maybe we will think about escalation from day 2 or day 3, whenever we are doing it. So if we are trying to throw a stone in the dark, we should at least throw in some direction. So I will just quickly show this reports. So to make it clear, this is one test from rectal swab. We can see this NDM and OXA is positive. So in this case, no point in continuing meropenem. So if this is a co-producer, if we are getting NDM and OXA, we can easily go with a Cazavi with aztreonam combination. These are the samples. we can do off level now. We can do off level also, but these are the recommended samples from the company. That's why I'm telling rectal swab and the isolates, clinical isolates.
But infection anywhere in the body will have a.
We can run, but off level. We cannot run on level. We can run off level. So in this case, we will not continue. Maybe we will not continue meropenem. Maybe we will think about escalating to Cazavi and aztreonam. There is a second test where we can see BIM and NDM is positive. So both are metallobutyl activators. So ideally, we should not go for a Cazavi aztreonam combination in this patient. Maybe we can think about adding colistin to meropenem in this case. And there is a third case, all green. So we can jolly well go ahead with meropenem. We know that we can surely say that the patient will improve with meropenem. So these all three are rectal swabs. So I have done from isolates also, just 3 examples. So now what are the drugs we have in hand? So firstly, what we have is ceftazidime-avibactam. Cazavi is active against KPC and OXA, and it is not active against NDM, IMP, and WIM. So yes. So next are the meropenem and meropenem-avibactam and imipenem-relebactam. They are only active against KPCs. Cefiderocol, it is already available in the European market. It is active against all the CARBAPENEMASEs, but the problem is that it has an increased 30 days mortality if compared against ceftazidime-avibactam. So ideally, cefiderocol is not recommended. Instead, we go for a ceftazidime-avibactam with aztreonam combination. Yes, sir. Yes, correct, sir. And this drug, it has crossed the phase 3 trial. Aztreonam-avibactam will soon hit the market, maybe another year, and maybe then, but there will be some mechanism of resistance. There will be surely. There will be surely be a mechanism. So this is the point. So we have to use our antibiotics very judiciously, very prudently, so that this drug is not lost. So we have to safeguard this drug. We have to safeguard colistin. Maybe we have to safeguard to some extent ceftazidime-avibactam also, because I have seen the resistance of Cazavi increasing to around 60% in my previous institution. So that is also alarming. আচ্ছা আমাদের ম্যাপ করা দিয়ে নেই later on they will include ma'am, they will include. Cephet is working on that. Cephet will include observant free also. Pardon, sir, I am not getting it. Yeah, yes, absolutely.
We should make it a point that these two drugs should not be started without consultation without medicine.
Here comes the antibiotic stewardship and the diagnostic stewardship also. So if we give a quick report from the lab, we can do it. So this was the CARBAPENEMASE testing, and I will just quickly show the benefit of the biofire testing also. So this is a sepsis panel. So if we
our patient looks like a septic, so all the clinical parameters like septic, but after 48 hours no flag is there, bad or urine or bacteria. In that patient, if I can send a rectal swab flag, and according to that, I can send my antibiotic.
yeah, absolutely, absolutely,
This is very important.
absolutely, sir. And you can send it previously also. You don't have to wait for 48 hours. If you see your patient deteriorating, and if you don't have to wait for the culture reports. You can do it. You can do the rectal swab as soon as you get the patient also. If you think that the patient is having, absolutely.
So we are having always a referral. We can, when the patient is coming, we can simultaneously send a blood culture and the rectal swab, right? Because they are dealing the infection from the.
We can do it. We can do it. So we have a solution for blood also. So we have a solution for blood cultures also. So this is the biofire for this is the biofire sepsis panel for blood. So what we do usually what we do is suppose we are taking a sample on day 0, or we get an isolate on day 1. If we are very lucky, we get an isolate on flag on day 1. So we plate it on day 2, and we get a sensitivity report on day 3. So instead of that, on day 1 itself, when the sample flags, we will just run the sepsis panel. We will get the organism. We will get the resistance pattern, including the CARBAPENEMASE resistance, including the colistin resistance. It will also cover the vancomycin resistance, and it will also cover the methicillin resistance. So it will cover both gram-positive and gram-negative bacteria, and we will get the diagnosis. So instead of waiting for 3 days, sir, we are getting a report on day 1 itself. On day 1.
Day 1 of flag.
So this is the benefit of biofire sepsis panel. So we can cut down like almost 72 hours, almost 40 to 72 hours with this. Yes, sir. We can easily start. Cons টা wastage যাবে, এবং cons টা মানে ideally we should not report cons from one sample. এখানে আমরা একটা করে sample নিই, but we should ideally take at least 2 samples. 2 blood samples is must. So if we are not getting 2 blood samples, we should not report cons at all.
That's why I always send 2 samples from PIC.
Ideally, sir, this should be done. Ideally, this should be the practice. If we are thinking about sending a blood culture, we should send 2 blood cultures, not 1.
If for neonate, it's okay. Because neonate will have.
Yeah, neonate is okay. So শেষ আর হয়ে গেছে। এটা জাস্ট লাস্ট ইয়ে মানে ক্যাপ রেজিস্ট্যান্ট ক্লেপশিয়া ট্রিটমেন্ট। আর এটাগুলো স্যার আমরা করতে পারি, এগুলো মানে আমাদের রেস্ট্রিক্টেড অ্যান্টিবায়োটিক ডেটা আর this is the hospital antibiogram we can publish so that we can be guided, the empirical treatment can be guided. Thank you, sir. না আমার নিজে আমার আগে এখানে করা নেই, আরে এইভাবে সব করে করা।